Imagine a condition that it doesn't just irritate your skin, but it literally acts like this, like a rogue shrink wrap.
Mm-hmm.
And it slowly just kind of erases the visible architecture of your anatomy.
Yeah, it's wild.
Right. It buries one of the most highly concentrated nerve centers in the human body.
Yeah.
But then this is the crazy part. It leaves it completely intact underneath.
Exactly. It's all still there.
So today, we are answering a really highly specific, deeply personal, and honestly just a completely overlooked question.
Oh, totally overlooked.
Which is, can a condition called lichen sclerosus affect the clitoris specifically?
Yeah.
We're doing a deep dive into this medical taboo today.
Yeah.
Because it leaves so many people just, suffering in complete silence.
It really does. The silence around this is just, it's staggering, honestly.
Yeah, and we're relying on some really crucial new data today, right? Like from the Lichen Sclerosus Support Network.
Right, and also the latest clinical guidelines from groups like the British Association of Dermatologists.
Which is huge.
Because of the societal discomfort with discussing vulvar anatomy openly, patients are just routinely misdiagnosed.
Like constantly.
Yeah, they get handed these creams for recurrent thrush or yeast infections, and they're just sent on their way.
Just dismissed.
Exactly. But lichen sclerosus is an entirely different beast. I mean, it physically alters the actual architecture of the body.
Right.
It can literally hide structures from view, but crucially, like you said, it does not destroy them.
Okay, let's unpack this.
Okay.
Because to understand how the clitoris is affected, we first have to understand the underlying mechanism, right, of lichen sclerosus, or LS, on the tissue itself.
Right, exactly.
So what is actually driving this architectural shift? Like, what's happening?
Well, at its core, lichen sclerosus is a chronic inflammatory dermatosis, and it's driven by an autoimmune response.
Okay, so the body's attacking itself.
Yeah, the immune system gets confused, and it mounts this attack on the body's own skin. Specifically, the research points really heavily to autoantibodies targeting a protein. It's called extracellular matrix protein 1, or ECM1 for short.
Okay, so ECM1, what does that actually do in healthy tissue? Like if I don't have LS?
Right, so think of ECM1 as the biological glue.
The glue, okay.
Yeah, it's the glue and the scaffolding that maintains the skin's structural integrity. It regulates collagen formation and also blood vessel stability in the dermis.
So it's super important for keeping everything, structured and healthy.
Exactly.
Yeah.
So when these autoantibodies attack and degrade the ECM1, that structural scaffolding just breaks down.
Oh, wow.
And the body panics, right. It tries to repair the damage by throwing down just an excessive, chaotic amount of collagen.
Like it's overcompensation.
Huge overcompensation. And this chronic inflammatory loop results in skin that becomes incredibly dense and scarred underneath. But visually it appears pale, thin, and kind of atrophic on the surface.
Right. The clinical literature often describes it as having this cigarette paper appearance.
Yes.
It's like it's all crinkled and exceedingly fragile.
Very fragile.
Which makes it highly susceptible to micro-tearing and fissures. And this battleground, it's highly localized, right? It's not happening all over the person's body.
No, not usually. It primarily targets the anogenital region. You'll often see this characteristic figure-of-8 pattern of affected tissue.
Right around the vulva and the anus.
Yes. It zeroes in on the labia minora, the perineum, and specifically the clitoral hood, which is clinically known as the prepuce.
The prepuce, okay.
But a vital diagnostic distinction here, and this is really important, is that LS almost never affects the mucosal lining inside the vagina.
Wait, really?
Yeah, it is strictly an external structural pathology.
Okay, so it's an external condition where the breakdown of that ECM1 protein essentially turns the body's healing process into a rogue shrink wrap.
A rogue shrink wrap. Yeah, that's a great way to put it.
It's tightening and fusing these really delicate external tissues together over time.
What's fascinating here is the stark distinction between what happens to the clitoral hood versus the clitoris itself during this whole shrink wrap process.
Okay, break that down for me.
So the clitoral hood is the fold of skin that surrounds, protects, and lubricates the gland's clitoris.
Right.
When the chronic inflammation of LS triggers that hyperdense scarring we just talked about, the hood can fuse. It basically tethers down.
Okay.
But the gland's clitoris underneath, it is completely untouched by the autoimmune attack.
So the actual nerve center is fine.
It is perfectly healthy. The vascular tissue is intact. The nerve endings are totally fine. It simply becomes buried or, trapped under that scarred, tethered hood.
But in the healthy anatomy, that hood retracts so things can be cleaned, right?
Yes, absolutely.
So if the hood fuses completely shut over the glands, what happens to the natural secretions and the dead skin cells? Because, I mean, they can't just evaporate.
No, they absolutely don't evaporate. And that mechanical failure introduces a massive clinical complication.
I can imagine.
It's called clitoral phimosis, or clitoral adhesions.
Okay.
So when the hood sticks to the glands and creates the sealed-off compartment, the daily accumulation of smegma gets trapped.
Smegma being the natural mixture, right?
Yeah, sweat, sebum, exfoliated skin cells, totally normal stuff. But because the patient physically cannot retract the hood for hygiene, the debris has literally nowhere to exit.
It just perpetually builds up in this microscopic sealed pocket. That sounds horrible.
It is. Over time, the water content of that trapped smegma is absorbed by the surrounding tissue.
Oh, so it dries out.
Exactly. What gets left behind dehydrates and solidifies. It forms these small, incredibly firm collections that the clinical literature calls keratin pearls.
Right. Keratin pearls. It sounds so benign,
Right.
almost elegant.
It really does sound pretty, yeah.
But looking at the patient accounts from the Lichen Sclerosus support network, they are the source of excruciating pain, like debilitating.
The pain is agonizing. The clinical analogy that's often used is it's like the sensation of having a grain of sand trapped in your eye.
Oh, God.
Right. Every time you blink, it scratches and it burns against a highly sensitive surface.
Yes.
Now take that sharp, hardened grain of keratin and wedge it underneath a tethered clitoral hood, pressing directly against the dorsal nerve of the clitoris.
Just wow. You are essentially compressing one of the most highly concentrated nerve centers in the human body against a calcified piece of debris.
Exactly.
Just the physics of that are wince-inducing. You have thousands of delicate nerve endings under constant, inescapable mechanical pressure.
Yeah, and the physical trap creates a compounding cascade of issues, too.
Like what else?
Well, this closed compartment can also prompt the formation of smegmatic pseudocysts.
Pseudocysts, so like fluid-filled sacs.
Right, fluid-filled sacs reacting to all those trapped secretions. And while they can sometimes be asymptomatic, the enclosed environment is basically a breeding ground for inflammation.
Which leads to more swelling, I'm guessing.
Severe erythema, yeah. And frequently, these pseudocysts can develop into acute abscesses.
Oh, no.
Yeah, which require immediate medical drainage to resolve the localized infection.
So we're talking about profound structural entrapment. It literally alters the fundamental function of the anatomy.
Profoundly.
Beyond the acute, localized pain of a keratin pearl or an abscess, how does this physiological entrapment alter the sensory experience of the patient?
That's a huge piece of this.
Because if the tissue is entirely restructured, the neural pathways have to be compromised somehow.
Yeah, to understand the sensory loss, we have to look really closely at the histopathology of the scar tissue that LS creates.
Okay.
As that ECM1 degrades and the body overproduces all that disorganized collagen, the resulting tissue is thick, rigid, and completely inelastic.
Doesn't stretch at all.
Not at all. So when that dense tissue fuses over the glands, it acts as a literal physical barrier.
Right.
Those thousands of nerve endings in the glands, they require direct mechanical stimulation to process sensation.
And they just aren't getting it.
Exactly. The rigid scar tissue absorbs and diffuses that stimulation before it can even reach the nerves, which results in a dramatic loss of sensation, heavily muted orgasms, or sometimes complete anorgasmia.
Here's where it gets really interesting, though. It's kind of like trying to read Braille through heavy winter gloves.
Oh, that's a perfect analogy.
Right. The physical information is right there beneath your fingers. The bumps are raised, but the barrier is just so thick and unyielding that your brain literally cannot process the tactile data.
Yeah, the thick glove effect perfectly illustrates the sensory barrier. But the functional problem is also deeply mechanical.
What do you mean?
Well, the clitoris is an erectile structure.
Right.
During sexual arousal, parasympathetic nerve impulses trigger vasodilation. This causes the erectile tissue of the corpora cavernosa to engorge with blood and actually expand.
Oh, right. But it's encased in an inelastic prison now.
Precisely. The biological drive for vascular engorgement is met with an unyielding wall of hyperdense scar tissue.
It has nowhere to go.
Nowhere to go. The tissue physically cannot expand to accommodate that increased blood flow. So instead of the natural expansion that facilitates pleasure, this extreme restriction causes severe pain.
Because the pressure is building up inside a sealed box.
Exactly. The clinical term for this pain during intimacy is dyspareunia. The physiological process of arousal itself becomes the source of the trauma.
Wow. Your body's own natural response to intimacy is weaponized against you.
That's exactly what it feels like for patients.
That turns what should be a connecting, pleasurable experience into a trigger for severe physical pain.
And this raises an important question, right? What does that systemic disruption do to a person's psyche over time?
It has to be devastating.
If we connect this to the bigger picture, we really have to examine the biopsychosocial toll. The recent clinical data actually includes this incredibly comprehensive mixed method study out of Aalborg University in Denmark.
Oh, right, the Danish study. They investigated exactly this dynamic, right?
Yeah, they didn't just run simple surveys. They utilized validated diagnostic tools like the Female Sexual Function Index, alongside in-depth qualitative patient interviews.
To really understand the psychological weight of this structural entrapment.
Yes.
And the numbers in that Aalborg study are they're a wake-up call. I mean, 75% of the women with lichen sclerosus were experiencing clinical sexual distress.
75%. It's massive.
And of the sexually active women, 68% scored dangerously low on that female sexual function index, placing them firmly in the category of clinical sexual dysfunction.
Yeah, and when you dive into the qualitative themes from those Danish interviews, you see the devastating psychological loop this creates.
How so?
Well, when intimacy guarantees physical tearing, intense burning, and that deep throbbing pain of restricted engorgement, patients naturally develop a profound fear of sex.
Of course they do. Who wouldn't?
Right, but this anticipatory anxiety actually triggers a sympathetic nervous system response.
The fight or flight mechanism.
Exactly, which prevents the pelvic floor from relaxing. And that subsequently makes the dyspareunia even worse. It becomes this terrible, self-fulfilling cycle of pain.
It's just a cascade of psychological grief. The interviews highlighted this profound interference with relationship dynamics, intense worries about sexual insufficiency, and just a devastating loss of identity.
Yeah.
It completely proves that the physical scarring on the clitoral hood radiates out to impact the patient's entire emotional world. It is never, ever just a skin issue.
Absolutely. The biopsychosocial model clearly shows that the isolation of the disease is honestly just as damaging as the physical tethering.
Yeah.
They lose the ability to connect with their partners, they feel fundamentally broken, and the lack of clinical awareness means they often suffer this grief entirely alone, believing that absolutely nothing can be done.
So what does this all mean for someone listening who might be dealing with this right now? I mean, we've outlined a heavy reality here.
We have.
Shrink-wrapped anatomy, trapped nerve centers, mechanical failure during arousal, and profound psychological distress.
Well, it's a lot.
It is a lot. How do patients intervene? How do they halt the ECM1 destruction, unfuse the tissue, and actually reclaim their anatomy?
Well, there is hope. The universal consensus across the major clinical guidelines from the British Association for Sexual Health and HIV to the British Society for the Study of Vulval Disease is that aggressive early intervention is paramount.
Okay, so acting fast.
Yes. The gold standard of medical treatment is the use of ultra-potent topical corticosteroids, predominantly clobetasol propionate ointment.
Okay, so because a standard over-the-counter hydrocortisone isn't going to penetrate deeply enough to stop the autoimmune attack on that biological glue.
No, it won't even scratch the surface.
Right.
The inflammation destroying the ECM1 is happening deep within the dermis. It requires a highly potent prescription steroid. And the application technique is incredibly specific, too.
How so?
Patients are often instructed to use what's called a soak and smear method, or to gently but firmly massage the ointment into the tissue for up to 90 seconds.
Oh, wow, so really rubbing it in.
Yeah, this mechanical action helps the medication penetrate that hyperkeratotic, thickened epidermis. In cases of partial phimosis, patients must be taught to carefully work the ointment directly under the clitoral hood.
To get right to the source.
Exactly. The objective is to forcefully halt the inflammatory immune response to prevent any further architectural fusing.
And halting that inflammation has another critical benefit, too. The guidelines note that consistent long-term use of these ultra-potent steroids mitigates the background risk of developing vulvar cancer.
Yes, that is so important to mention.
While the risk is relatively low, roughly 5% for patients with LS uncontrolled, chronic inflammation is a known catalyst for squamous cell carcinoma. So the steroids act as a profound protective measure.
They really do. Suppressing the inflammation and protecting against cellular mutation is step one. But we also have to address the structural fusing that has already occurred.
Right, the shrink wrap.
For early stage or mild clitoral phimosis, the British Society for the Study of Vulval Disease guidelines outline targeted self-management techniques.
Things the patient can do at home.
Yes. Patients are instructed on how to apply gentle, consistent traction to the hood, carefully pulling the skin apart twice daily to sort of divide the forming adhesions.
Which requires a tremendous amount of patience because you are actively manipulating fragile, highly inflamed tissue.
It's not easy. To make that self-management tolerable, the guidelines recommend applying a 5% lidocaine ointment approximately 20 minutes prior to the traction.
So it numbs it up a bit.
Exactly. This numbs the area, managing the stinging and pain associated with separating that delicate tissue. The ultra-potent steroids are continually applied during this phase too, to suppress the immune response as the skin separates.
That makes sense. The clinical literature also highlights the efficacy of myofascial release, or MFR, for these adhesions.
Yes, working alongside a specialized pelvic floor physical therapist trained in MFR is a highly effective, non-invasive intervention.
How does that work?
Well, these specialists use targeted, sustained mechanical pressure and stretching techniques to actively break down the rigid, disorganized collagen of the scar tissue.
Okay.
By breaking up those crosslinks in the fascia, they can gradually restore elasticity and mobility to the clitoral hood without causing shear trauma to the skin.
That's amazing. But when we look at severe phimosis, where the hood is just completely sealed, the keratin pearls are calcified and trapped, and the braille is entirely unreadable through that thick glove of scar tissue. I imagine gentle traction and MFR simply aren't going to break through that barrier.
Unfortunately, no. In severe cases, surgical restoration becomes the most effective path forward.
Okay.
The procedure is a highly specialized lysis of adhesions. However, and I cannot stress this enough, it is absolutely critical that this is performed by a clinician who specializes specifically in lichen sclerosus.
Right, because of that physiological response known as the Koebner phenomenon,
Yes, exactly.
where the body interprets the surgical incision as a traumatic injury. And instead of healing normally, the immune system floods the area with more Ellis-specific inflammation.
Right. The surgery itself can trigger a massive autoimmune flare-up, potentially resulting in even worse scarring than before.
Which is the exact opposite of what you want.
Literally the opposite. So, to circumvent the Koebner phenomenon, specialists employ highly specific surgical techniques. They often utilize needle diathermy.
What's that?
It uses a high-frequency electric current to precisely separate the fused tissue with minimal bleeding and tissue trauma, rather than just, cutting with a scalpel.
Oh, interesting.
And most importantly, they administer intraoperative steroid injections directly into the surgical site. This immediately suppresses the local immune response and prevents the Koebner flare.
Wow. So they literally unbury the gland's clitoris, clearing out the trapped keratin pearls and restoring the physical real estate. And the documented outcomes from these specialized surgeries are genuinely incredible.
The clinical literature presents a very encouraging prognosis. There was one detailed case study from the patient advocacy research that followed a woman with complete severe clitoral phimosis.
How'd you do?
Following a specialized lysis of adhesions, her recovery was rapid. Just 11 weeks post-surgery, she reported a 100% return of clitoral sensitivity.
100%. Wow.
Yeah. The anatomical mobility of the hood was fully restored, her dyspareunia completely resolved, and she experienced a full return of normal orgasms.
11 weeks to reverse years of entrapment and pain. It perfectly illustrates the core truth of this condition, right? The structural damage, while devastating, does not have to be permanent.
No, it doesn't.
The anatomy wasn't destroyed, it was just hidden.
Exactly.
For you listening, this is the ultimate takeaway today. Lichen sclerosus absolutely can and does affect the clitoris specifically. It alters the architecture, it buries the nerve center, and it triggers a really heavy biopsychosocial toll.
Yeah.
But the clitoris is still there. It's intact, waiting beneath the surface. With the right clinical knowledge, specialized specialists, potent topical treatments, and targeted therapies, that anatomy and your capacity for pleasure can be completely restored. You are not broken. Understanding the mechanics of your own body makes you an empowered self-advocate, and in the medical system, that changes absolutely everything.
It really does. And if an autoimmune condition can so profoundly and silently alter our external anatomy and our sensory experiences by essentially building thick walls over our most sensitive nerve endings, what does that imply about the complex, undiscovered ways our immune systems might be slowly reshaping other sensory organs or internal nerve pathways throughout our lifetimes?